Well, it's not going to go away for a variety of reasons. Let's just start with metastatic disease. So even in patients who have very significant benefit from immune therapies, many of those patients, not many, but some of those patients don't get to a complete response. They have one or a small number of residual lesions. And in some of those patients, if you resect those lesions, they have substantial benefit. They remain progression-free for very long periods of time. Sometimes you need surgery. Even if you have very effective systemic therapies, you still need to do surgery. If somebody comes in with a bowel lesion and they're bleeding, you may need to resect that before you start their treatment because they may not respond so quickly. So surgery, even in metastatic disease, still has a major role. Now, if you go back to the primary setting, still we'll be doing wide local excisions, and I think there's still a role for a sentinel node biopsy because a sentinel node biopsy gives you prognostic information. So even though it doesn't prolong survival to do the sentinel node biopsy, at least medical oncologists don't think so, it does give you really important prognostic information, and so it tells you whether somebody needs adjuvant therapy or not. Right? So it's going to be important, even if we don't do the completion lymph node dissection. Now, there may come a time when the treatments become so effective that you make the diagnosis of a primary melanoma, you take it out, and then you just give somebody systemic adjuvant therapy without any further surgery. We might get to that point at some time in the future, but you really have to have an incredibly effective systemic therapy. We may be close to that, and something that has very little toxicity and something that you can give for a short period of time with relatively low cost.